Assalamu alaikum, the clinical day. First scenario, Mr. Brandon, 40 years old male, presented with bloody diarrhea for 2 weeks of duration. Please take history and do correlated physical examination as well as answering his concerns. If you are ready, Dr. Huda, we can start with Dr. Muhammad.
Yes. Okay.
Okay, here you go.
Hello, my name is Dr. Huda, one of the doctor in the clinic today. I'm talking to Mr. Ahmed.
Yes, I'm Brandon.
Brandon. Okay. Mr. Brandon, we are here to discuss some issue related to your health condition. Is that okay with you?
It's okay, yes.
Yes, I have letter from your GP stating that you have a bloody stool. Can you tell me more about that?
Well, doctor, I was having some blood in my stool. It was for around 2 weeks ago, but I feel I'm tired. I feel I have body ache, complaining of some fever, raised temperature.
Yes.
Yes, yes.
And before these 2 weeks, everything was normal.
Uh, let's say no, it was not normal totally. For 3 months ago, I have on and off abdominal pain and diarrhea, but in this last 2 week, this bloody diarrhea makes everything worse to me, and I feel there's something serious.
Okay, and at that time, did you seek any medical attention for your tummy pain?
Yeah, I have visited many GP doctors and internal medicine doctors. But up to now, nobody knows what's going on with me.
Okay, I'm very sorry about that. But at that time, is your loose motion associated with the blood?
No, it was normal. It was watery only.
Okay, okay. So during this 2 weeks, did you notice anything increase this bloody loose motion?
Nothing specific.
Like a specific type of food?
I don't think so.
Okay. And can you tell me more about this loose motion? Is it fresh blood or not?
Occasionally, I see fresh blood, but most of the time, the blood is mixed with my stool. And yes,
Okay. And does it associated with any pain when you pass motion?
mild pain, yes. Yeah,
Okay.
there's pain.
Okay. And do you have any, you say that you have a tummy pain also.
Yeah.
Can you just point to me exactly where this tummy pain you feel it?
I cannot specify. It's all over the abdomen. Sometime in my lower left, sometime in the upper right. It's not specific, yes.
Okay. And did you notice any swallowing or a certain mass in your abdomen?
I don't feel it. No, I don't know.
Okay. Okay. Did you notice that that this tummy pain go to any other side of your body, like your back sometimes?
The pain is not so much, doctor. It's not frightening me a lot, but
Okay.
yeah, the loose motion was too much. Yeah,
Yes. And is it this loose motion with the blood? Is it large amount or small amount?
it's large amount.
Okay. I'm very sorry about that. Okay. So do you have any eye redness or eye itching?
Yes, I feel some grittiness in my eyes.
Any redness?
Yes,
And do you have any mouth soreness?
no, no mouth soreness.
Okay. Any joint pain?
I noticed there is some pain in my left knee.
Okay. And can you tell me more about this pain
Okay.
in your knees?
The pain is somewhat dull, okay, and it's about moderate intensity, somewhat around yeah,
Okay.
5 to 6/10.
Okay. And did you notice like this knee pain is mainly when you move or even at rest?
It's all over the time during the rest and more with movement.
Okay. And do you use any medication to relieve this pain or your tummy pain? Any medication?
I have been using some medication, yeah, since long while, yes, but no benefit from it.
Yes, can you tell me just briefly what medication?
They told me that some of the medication is belong to called anti-germ medication.
Uh-huh. Okay, any other medication other than this?
Some pain medication, yeah.
Painkiller medication, yes.
Painkiller, yes.
And it's on and off or use it all the time?
Could you repeat, doctor? I didn't get.
Do you use this pain medication all the time?
No, it's intermittent, no.
Okay. Okay, so you told me that you don't have a back pain. Do you have any stiffness in your back?
No,
Okay. Okay, with this bloody stool, did you have any that mixed with the blood? Did you notice sometimes it's difficult to flush away?
no,
Any offensive odor sometimes?
no,
Okay. Okay. Okay, so can I ask you any use of any herbal medication?
no.
Any raising in your body temperature? You tell me that
Yeah,
you have some
yes, I
raising
have.
body
Yep, I
temperature,
have.
but did you check it recently?
Yeah, it was 37.8.
Okay. And any specific time that your body temperature is increasing?
I didn't notice this. No, I
Okay.
don't.
Okay. Any sweating?
No,
Any changing in your body weight?
yes, I feel I have lost around 4 kg in 3 months.
Okay. And what about your appetite?
Appetite is not bad, but because of pain, I'm afraid to eat anything.
Yes, I can understand that. And okay, any lumps or bumps anywhere in your body?
No,
Okay. Any one of your family having same condition recently?
my sister also has some bowel problem. I don't know what's going on. She also has long-lasting loose motion.
Similar to your complaint.
Yeah, but not like this. I have this serious condition.
Okay. Any disease running in your family?
My mother has thyroid problem.
Mm-hmm. Okay. So, did you eat anything like unusual from outside recently or previously?
I cannot live without eating at restaurant. Yes, I'm eating a lot outside.
Okay. And did you have any episode of a bloody stool after eating from outside, or it does not even related? You think it's not related?
No, I don't think it's related.
Oh, okay. Do you have any contact with someone with TB or tuberculosis? Did you hear about it before?
Yeah, I heard about TB. No, I don't think so.
Did you travel recently to any area?
No,
No. Okay. So any skin rash anywhere, mainly, I will ask you mainly on your leg sometimes.
no,
Any other side of rash or skin discoloration?
no.
Okay. Okay. So, okay. Do you have anyone commenting that you look paler than usual?
Yes. Too many
Okay.
persons are saying this.
Okay. And do you have dizziness mainly when you standing from a sitting position?
Occasionally, yes.
Okay. Did you notice that your skin are more dry, or are you feeling more dryness recently?
Yes, I feel it. Yes,
Okay.
I'm dry. Yeah.
Okay. And okay. Any neck swelling?
And the neck swelling?
Mhm.
No, I don't feel it.
Any weather preference?
No,
No.
totally normal.
Okay. Okay.
Mhm.
Okay, Mr. Brandon. Okay. Do you have any surgery in the past?
No,
Okay. And do you have what do you smoke? Do you drink alcohol? Sorry.
no.
No. Okay. And what's your job?
I'm an employer.
Sorry.
Employee.
Okay. And did you think this affecting you in your job?
Yeah, definitely. Yes, I
Yes.
cannot do anything.
Yes, I can understand that. And we would try to give you some sick leave and maybe even involvement of occupational health worker to see how he will help us in this regard. Is that okay with you?
Oh, yeah, thank
Okay.
you.
So now, Mr. Brandon, I want to examine you.
Okay.
So first, I will just try to look to his general build, any decreasing in body mass index.
Body mass. Okay. BMI is 25.
Okay. Any did he look cagestic or not?
No, I'm not cachectic.
Okay, and then I will just try to wash my hand and then look to his hand, mainly looking for any clumping or cholinicia or leukonychia.
Leukonychia.
Okay, and then I will turn to looking for any pulmonary erythema and then checking for the pulse of the patient. Is it any tachycardia?
Tachycardia, low volume pulse. The pulse is around 110.
Okay, and then I will go to his wrist asking for checking the blood pressure.
It's normal. 110 over 70.
Okay, so I will ask to measure blood pressure sitting and standing, looking for postural hypotension.
No orthostasis.
Okay, and then I went to look for his eye, looking for any pallor and jaundice.
Yes, there's jaundice.
Jaundice, pallor.
There's pallor also. Yes.
Okay. When I take a history, can I ask you, Mr. Brandon, you have any episode of itching?
Yes, I have itchiness in my whole body.
All over your body. Okay. Okay. And then I will put a torch in his eye, looking for any eye redness.
There is eye redness.
There's eye redness. And then I will ask him to open his mouth, raise his tongue, looking for any soreness or any cyanosis.
Yeah, there is oral ulcer, single oral ulcer.
And I will ask him, is it painful, this oral ulcer?
Painless, no.
Okay. And then I went to his abdomen, just adjust the bed in supine position. And then I will look for any scar in his abdomen, any scar or any obvious mass.
Abdominal distension, generalized tenderness, and high temperature of the belly, yeah. And there is
Yeah.
some distended superficial veins.
Okay. And you mean capotomidosa?
No capotomidosa, no.
Okay. And then I will look just to palpate for organomegaly, mainly for splenomegaly.
Tense,
look
because of tense abdominal distension, I cannot feel, or you
Okay.
cannot feel the organomegaly, yes.
Okay, then I will do shifting dullness.
Negative.
Okay, and then I look down to her leg, looking for any rash of like erythema nodosum or any other rash.
Yeah, there is small size, around 2 by 3 cm red skin lesion over the legs.
And I will ask him, is it painful?
Is it? Yeah, it is painful.
2 minutes left.
Yeah.
Okay, and looking for pitting edema also.
There is mild pitting edema. Bilateral.
Okay. Okay, so Mr. Brandon, can I ask you what's your concern?
What's going on with me, doctor? I need a diagnosis.
Yes, I highly appreciate your concern, but Mr. Brandon, from when I take history from you and after examine you, most likely you have a condition called an inflammatory bowel disease, and it's called ulcerative colitis. It's a medical term for a medical condition in which there is affection of the lining of your bowels because of defect in the defensive system. And this is affection of the lining of the bowel leading to the bloody stool that you have and raising in your body temperature. And also these joint pain and fatigue that you've been feel. So what we need to do is to run for you some blood tests and maybe some camera tests. Then we will sit further to discuss what will happen next. Is that okay with you?
Yeah, it's fine.
Do you have any other concern?
But why my eye color is changed? I think it's yellow. What's going on with this? Is it related again to this disease, as you mentioned, IBD?
Yes. Yes, it's this disease affect multiple organ in your body. It's maybe affect the lining of your bowel, or could even affect the what we call it, the your liver, and this the what we call the gallbladder sometimes in your liver, and this when get affected, leading to increasing amount of this yellowish pigmentation and the manifestation of itching that you have. Yes, it's related. Could be related.
Do you think, doctor, those antimicrobials prescribed to me has a relation with this condition? Because I think I get too many medication.
Yes, there is possibilities. There's many medication that you've been prescribed previously could lead this to this manifestation of yellowish discoloration in your eyes. So as I mentioned, there is many possibilities, maybe related to your disease, or could be related to this medication, as you say, for sure. And so, as I mentioned, we need just to know what exactly you've been taking this medication, and even after running off a blood test and doing this camera test, we will know what was happening exactly.
Okay, thank you, doctor.
Okay, time is up. I usually extend the time to listen to more concern and to know how to address all concern. Examiner question now, please. Dr. Muhammad, you can start.
Thank you, Dr. Huda. You were systematic initially. Let's start from history.
No, Dr. Muhammad, the questions.
About the diagnosis.
Examiner.
Okay, what could be your differential diagnosis, doctor?
Yes, the first differential diagnosis would be ulcerative colitis. The second would be Crohn's disease, or could be related to infection, or could be related to infiltration, such as cancer.
Other differential?
Or could be associated blood thinning medication, or could be associated with the tuberculosis.
But there was no any history, drug history or TB history, right?
Yes, it's
Okay.
more likely
So,
associated with inflammatory
other
disease.
related differential?
Yes. Yes, it's colon cancer.
The jaundice points to what?
A primary sclerosing cholangitis.
Okay.
Yes.
Okay. What else?
A primary biliary cirrhosis.
Apart from jaundice, other differential in regard to this bloody diarrhea?
Could be liver disease with associated coagulopathy, maybe.
The patient has abdominal distension, fever, pain.
But yes, I could not specify more.
Pseudomembranous colitis. Okay. Okay. How would you evaluate? How would you investigate this patient?
Yes, I will run some blood tests routine, from complete blood count, renal function test with liver function test, and serum electrolyte. And then I will confirm my diagnosis by sending colonoscopy and imaging to her abdomen by ultrasound to exclude any mass or any associated thing with the disease. General stool analysis. Yes. Yes.
What else? Specific diagnosis?
I will
What is the diagnosis?
Yes, fecal calprotectin and the inflammatory marker.
Okay. Did you mention histopathology?
No.
Okay. So biopsy through the colonoscopy.
Yes.
can help us with this problem. What else? I have-
Exclude any associated complication,
Mhm.
such as maybe endoscopic retrograde cholangiography, to exclude any associated primary sclerosing cholangitis. Yes.
Do you need
Yes.
any antibody testing?
Specifically, no. Doesn't anything come in my mind now.
How would you treat this patient?
Yes, first educate the patient about her disease, his disease, and involving a team of doctors, including a gastroenterologist and nurse doctor, and even a dietitian. And the treatment would be depend on whether it's an acute flare of ulcerative colitis. If it's acute, then would be managed by oral aminosalicylate and even steroids. Whether the on to prevent these attack will depend on giving maybe azathioprine and mercaptopurine, disease modifying agent, and even vitamin supplementation. Yes.
Okay. Based on what scoring system you assess the severity of this patient? I'm sorry, Dr. Basim.
Yes. Called True Love criteria. This will assess the severity of ulcerative colitis, and it's depend on the fever grade, on the ESR level, the amount of stool frequency, if it's more than 6 times per day. Yes, what I remember actually.
Which test is more specific for PSC?
PSC, it's
Diagnosis.
primary sclerosing cholangitis would be diagnosed by ERCP, endoscopic retrograde cholangiography.
Yeah. Okay. How do you know this patient has no perforation from pseudomembranous colitis?
I don't have any idea actually.
Any investigation you need to send?
Maybe an urgent erect abdominal X-ray to exclude any fluid level.
More specific than X-ray?
To exclude perforation, maybe.
Okay.
No, actually.
No.
Okay. CT abdomen.
Okay.
Okay. What investigation you have to send during the ulcerative colitis flare?
Yes, it's mainly abdominal X-ray to exclude toxic megacolon.
This first. Give me 4 investigation.
Sending for an inflammatory marker. Yes.
Okay. That's it.
In my
Perfect.
knowledge.
Really perfect. Very nice. And the most fluent practiced scenario ever. The question and the answer quickly. And the way of the questions and the frequency of the questions is very excellent. You don't have any mute, you don't have any quiet silence for any time. Very nice performance, Dr. Huda. And also the analysis, everything you did great. Let's hear the Dr. Muhammad comment, then I will comment.
Okay. Thank you, Dr. Basim. Dr. Huda, thank you for this nice case evaluation. Really, you did an amazing job. Let's start with history. It was perfect. But in history of presenting illness, you have to focus on Once you reach, I think from a few questions, you reach the diagnosis of IBD. Then you have to fight for extraintestinal manifestation and complication. This is for IBD because the bloody diarrhea differential diagnosis is not so wide, like watery diarrhea. We have limited differential, but so now we have to search for extraintestinal manifestation to differentiate from other pathologies. This is first. The past medical history, you have to focus mainly on other GIT manifestation and take the detail of, in history of resin, again, take the detail of GIT. Starting from oral, you did perfect. You asked for oral ulcer, but what about dysphagia, odynophagia, vomiting, abdominal distension, constipation? Okay, we have to manage GIT as well as the liver manifestation by history, like itching. Although you asked for itching later on, but it was better to be taken initially with GIT. So liver symptom itching, abdominal distension, abdominal fullness, and jaundice, change in urine color, change in fecal color. All this should be taken in history of presenting illness initially. And regarding past surgical, it was good, past medical, good, but the drug history, you have to focus mainly on other medication, antibiotic, and herbal. You have to ask, I think you asked for herbal, but ask more about the hormonal therapy, and because the patient will not give you the medication directly, and the doses of antibiotic was taken IV or oral medication, what kind of antibiotic was given for upper respiratory or for GIT. You have to go more in this point. And family history, I gave you hint that my sister and my mother has autoimmune disorder. So you have to then search for related autoimmune disorder. You know that this patient is IBD, but once you reach the diagnosis, this does not mean that everything is finished. No, because it might be there might be some correlated autoimmune disorder, or there might be some complication of IBD itself. Better to ask more about this. And social history, you didn't ask for smoking, and about counseling of smoking cessation, and marital status, hobbies, habits. All this should be taken seriously, and even sexual relation outside of marriage, because you know the HIV related with diarrhea also, and all this should be taken seriously. Nothing specific in review of system apart from genitourinary symptoms. I think you forgot the review of system. For the next time, it's better to be taken. For physical examination, it was good, but it's better to start with the primary pathology. Although you did the initial steps, hand examination, face exam, and oral, but you forgot the lymph node examination and oral dryness. You asked for oral inspection, but you forgot the oral dryness. There was single ulcer, and ask for the more detail of this ulcer. How frequent there was any genital ulcer, because if it's also associated with genital, might be bahjat, also one of the possibility. Okay, and abdominal examination, bowel sound, you forgot. Although abdominal palpation and superficial palpation and deep palpation a little bit painful and boring in this patient, and makes irritability. And lower limb exam, you did well. Initial evaluation, regarding the approach of management, initial evaluation, it was good, but better to say the basic investigation and bedside investigation for this patient, because the patient is irritable, and then advanced investigation and investigation to rule out the complication. As you know, the IBD associated with too many complications, whether bowel or extra intestinal. and all this should be taken seriously. And this is now the patient in UC flare. So you have to send for some investigation to rule out the cause of UC flare, which is very important, including the cytomegalovirus, CRP, calprotectin, and as well as the CDI toxin A and B. All this important because we are focusing now on the primary pathology. Then related pathologies. Lines of evaluation, the most important part of management. For now, you have opportunity, or you have the priority to give the IV fluid resuscitation, hydration, nutritional support, and giving steroid, which is important, albumin, because I have leg edema, and as well as giving the other therapies to cover the UC, ulcerative colitis, and to search for the treatment of complications, okay, including broad-spectrum antibiotic, paracetamol to cover the pain, and as well as antiemetic if it's present, but avoid the anti-motility agents to prevent further complication. That's all. Thank you. You did well, and best luck in other opportunities.
Thank you, Dr. Muhammad. Very nice comment as well. You comment about everything missed by Dr. Huda. Although she did great, she reached diagnosis, but she missed a lot of questions, which I guess it might harm the mark of communication, clinical communication. Since she didn't ask about system review, I don't think she asked about heart questions or cardiovascular system, heart awareness of the heartbeat or chest pain, short of breath, any cough, all these questions, and the urine, of course, the genitourinary, as Dr. Muhammad mentioned. So this is regarding the system review itself. I guess you missed these systems, and it will be positive in this scenario. Like because of anemia, the patient will have, of course, palpitation, and he might have anemic signs and symptoms, or pallor, any dizziness from standing. You asked this question, so it's related to cardiovascular. The next system missed here, short of breath or coughing. Why do you think the coughing and short of breath here is important, Dr. Hoda?
Maybe related to tuberculosis.
Perfect. Direct question and direct answer. So if you suspect TB, extra respiratory TB or miliary TB, it could be also one of the causes, and it will be one of the differential because he's having also constitutional symptoms. So you have to ask this system particularly. Always remember the system review to ask all questions about other systems. It might be the case, and you will miss the system, and you will miss the case. So if you miss the TB in the chest as pulmonary, then extrapulmonary, you will miss the case, okay? Always forget to ask this question. It's 2 questions every system. Cardiovascular, heart, any chest pain or awareness of your heartbeat. In the chest, any short of breath or coughing up blood. It will direct you to the case. The genitourinary, any passing blood. And I wrote also comments about blood here. Any bleeding anywhere in your body is very important question, as well as any blood thinner medication, as Dr. Muhammad said. Also another important question. The patient might be on warfarin, and you will miss the whole case. Please be sure that you miss the blood thinner medication. Any history of blood thinner medication? Apart from system review, we'll go to the social. The social here important in the family history. I wrote also in the comment, cancer colon particularly as a question. You ask about any family history of same condition, and he told you, yes, I have some cousin about bowel or gut disease. What about cancer colon? Is it important question? Again, whenever you have diarrhea with blood, the patient or surrogate will give you a question in the concern. Doctor, is it a cancer? And believe me, you will be a trouble in answering this question. Why, Dr. Huda? Why do you think this is significant? What it signify if you ask about or you miss this question? What do you think?
Actually, nothing in my mind now, but
Okay, so do you think, is it a cancer?
yes, cancer, one of the
Exactly, perfect.
possibilities.
So it's one of the differential as well as it is one of the concerns. And if you didn't roll it out from the family history, you will be in trouble. He might tell you, doctor, as at the end, of course. If he asks you this question again, you will lose the trust and you will be more panic. If he asks you, doctor, is it cancer colon like my mother or grandmother or my cousin? You'll be in trouble. Always remember this question, particularly question. Any bloody diarrhea or any loss of weight or any constitutional symptoms, put the cancer one of the possibility. So ask clear and direct question. Any cancer colon in the family or any cancer lung, it's not dependent only on this scenario. Other scenario with constitutional symptom, you suspect a cancer, put the cancer question in the family history as a clear and direct question. Okay. Okay. This is the point related to the social. As Dr. Muhammad said about HIV, sharing needles, again, it's one of the possibility. HIV and any losing weight, any bloody diarrhea, it would be a differential, and I should screen about them. Any sharing needles, tattooing or piercing, blood transfusion, since he has jaundice, why not is related to hepatitis? Okay, so always remember this question. I believe you did a great job. Your question was fluent. Your history taking was very perfect. But if you direct the question, it will be more better. Okay. The last thing, as you ask about alcohol, you have to ask about smoking. I don't know why you missed. You were about to ask smoking, but then you said, "Do you drink alcohol?" So what
Yeah,
is the
because smoking, it's improve ulcerative colitis.
perfect?
Better to
I,
be avoided.
yeah, perfect. But how do you know this is the case? What if the case is not ulcerative colitis?
I just get it from the history, bloody diarrhea, tinnitus.
By the way, Dr. Huda, the
Uh,
history and the examination will not give a clear diagnosis. You are here just to give a differential. I know you can say it's possibility and high possibility as a disease here, but still you have to do some tests. It might be Crohn's. Why not? It might be a cancer. Even it is ulcerative colitis and it is improving with smoking. You have to advise about cessation. Why? Because the smoking will harm the whole and general health. Even it improve the ulcerative colitis relapse, but in general, it worsens the general condition and it might lead to cancer, right? So it's not the concern about ulcerative colitis itself only. We
yes,
always advise about smoking for the general health, not only for the diagnosis.
yes, I thought just better not to even mention it.
No,
Not
no, no, no. No, it's okay. Try.
Dr. Huda,
Yeah, go ahead, Dr. Mohammed.
I have two questions for Dr. Huda. Suppose this patient has a wheezy chest.
Yes,
What could be in
perfect.
your mind? First differential,
carcinoid,
wheezy chest,
uh, carcinoid, but not with a bloody. Um,
related to IBD, bronchiolitis obliterans.
mm,
Yeah, it's related to IBD, especially ulcerative colitis. Second question, Dr. Huda, what factor or which symptom not related to disease activity in IBD?
mm,
Symptom or sign?
erythema nodosa.
No, it's related.
Mm,
Give me two symptoms which is not related to disease activity. Pyoderma gangrenosum
yes,
and primary sclerosing cholangitis.
yes.
So what we call them, Dr. Mohammed? Is it? It's not related. So what do you mean?
Means whenever we have, for example, this jaundice, this not means the ulcerative colitis has activity. The
Ah,
VUC
okay.
flare is not related to the PESC, related to maybe infection or antibiotic or whatever the source, but not related directly to the PSC, primary
Perfect.
sclerosing. And the second
Perfect.
one, pyoderma gangrenosum, once we see this patient has pyoderma gangrenosum during examination, better to say this pyoderma is not related to the current status.
Perfect. Okay. Thank you, Dr. Muhammad. Other points, as Dr. Muhammad mentioned, the antibiotics and ruling out pseudomembranous colitis, which is very important here to rule out Clostridium difficile infection. Even the patient is ulcerative colitis, he might receive antibiotics and he might have this condition. So it's not related only to a healthy patient. It might be also related to patient with any disease, right? So it might happen with any patient taking antibiotics. Okay, Dr. Huda. So you have to screen about the course of antibiotics, when exactly it was, and is it related directly to the antibiotics or any previous infection? I think you asked, but you didn't analyze them more. Is it clear?
Yes, clear.
Okay. But in general, really, as a first practice, you did a great job. I
Okay.
guess you success this case if in exam, you did it in a perfect way. Dr.
Thanks.
Muhammad also prepared the case well. He has prepared the knowledge-wise, the questions. I like the performance for both of you today.
Thank you,
Okay.
Doctor.
If I just I didn't like prepare the case like well, but I hope I will do
It's
best.
okay. Anything, at least you know the concerns and
Yeah.
the same scheme for the questionnaire or the questionnaire of the examiner. I think for all patient and all scenario, as well as in the exam, they will ask you the same question. Present your case. What are your differential? How to investigate? Would you admit? And the last question, how to manage? That these are the most common question in any long clinical consultation case. Even you didn't prepare well, just ask this question and we will comment about these question after finishing the discussion, okay?
Okay.
Can you post your case, please? I will read the comments in the chat box.
Assalamu alaikum, Dr. Basim.
Alaikum assalam, Dr. Azhar, yes.
In the differentials, since the history of fever, can we put spontaneous bacterial peritonitis also in the
Can you,
differential?
yeah, please, can you raise your sound? I heard you, but I guess your sound a little bit low. Okay.
Can we put, in the context of fever, can we put SBB in the differentials?
Okay.
Because
What do you think if...
I'm not sick, I'm not feeling well. Since I came from Makkah, I'm having.
Oh my God, salamat. Yeah, salamat. Salamat. May Allah
Dr. Azhar.
give you recovery soon. Salamat, Dr. Azhar. Okay, I will answer this question. I guess there is no ascites in this case, so I cannot say this is spontaneous bacterial peritonitis, because always the spontaneous bacterial peritonitis happen on the background of ascites. Sorry?
Why the abdomen was distended, Dr. Muhammad? He told that abdomen is distended.
I think it was not shifting dullness. Dr. Muhammad, any distinction in this case?
Yes, he told no shifting dullness, but why the abdomen was distended? There was some appearance of he told like spider nevi. I think he was talking like this.
Excuse me,
Dr. Azhar?
Dr. Basim.
Yes.
This case, I think two diagnoses. The patient is having ulcerative colitis or inflammatory bowel disease, and as a result of the antibiotics he received for the diarrhea from the GPs, he also has the membranous colitis. Is this right, Dr. Muhammad?
Yes.
Yeah, it was correct. Yeah.
Yeah, that's
Pseudomembranous,
why
was the
pseudomembranous. Yeah.
definition.
Yeah. So the finding in the examination was about that. I don't know.
Yeah, it was
But
gaseous distension. Yeah.
Yeah, but when you said jaundice, abdominal distension, and pain, I was searching for also thrombosis, but diarrhea. I was thinking if it is also a possibility, but I searched for the complication of IBD. I didn't find this. I don't know. What do you think, Dr. Muhammad?
Yeah, last time I prepared one case with Vatkiari.
Mhm.
Yeah, I afraid to add Vatkiari again to this case because it will become very long case.
But it is a possibility, right?
Yeah,
Not
definitely.
only
This is inflammatory
sclerosing
disorder.
cholangitis.
Yeah, it's an
Yeah.
inflammatory disorder. Yeah.
It came to my mind, yeah, when you are discussing the findings. Because
Okay.
in pseudomembranous colitis, uh, what are the examination findings we will find?
Tenderness, abdominal tenderness,
Mhm.
right?
Yes.
Surgical abdomen only,
Yeah,
generalized tenderness.
yes,
There will
exactly.
not be hepatomegaly or anything else.
Yeah. I guess no hepatomegaly here, Dr. Muhammad. He said no hepatomegaly, right?
No
Yes,
hepatomegaly.
No hepatomegaly. Okay.
told that
Okay,
abdomen is distended.
okay, my mistake,
That's why
my mistake.
I could not find any
No.
organomegaly. Why
Yeah.
abdomen was distended in this case?
Dr. Muhammad, I guess there was no distension in this case, right, Dr. Muhammad?
There was some
No,
distension because of sedum.
no, he said
For me,
distension
Distension.
I think
Okay.
and veins also. He said distension and
Yeah. Dilated
obvious
veins.
veins,
Yes,
Yeah.
dilated
obviously.
veins. Yeah.
Yeah.
Dilated vein. Yes,
Yeah.
he told.
So what's the cause of distension? Is it gases?
Again, yeah, from all it's from gases distension. Yeah.
Yeah.
bowel
Uh,
lobe irritation.
the veins was not engorged. The veins was just distended. So this is related to the stretching pressure or stretching effect from the gas.
Okay.
Yeah.
Okay. Okay. Let me add one more examination you have to offer, Dr. Huda, in any blood diarrhea or blood in the stool. Digital rectal examination is very important examination to do, or at least offer it. Of course, he will not do or not allow you to do either from examiner or from the patient side, but offer it. I would like to do digital rectal examination. Or you can say, if I have time, I would like to do digital rectal examination. Okay, this is one of the important thing you have to offer it in bloody diarrhea. Okay. The question also for previous attack, I guess you didn't ask, Dr. Oda. I remember this point. Sorry for adding again few comments. Uh, any previous attacks of bloody diarrhea, you have to analyze it. Okay. And I prefer when you mention to the patient you have a condition called inflammatory bowel disease, don't specify which of them, ulcerative colitis or Crohn's. You can say most likely. You are not here to give him definite diagnosis. Although the symptoms are likely to be, of course, ulcerative colitis, but still you didn't do the test. You don't have clear diagnosis unless you do the investigation and the imaging and, of course, the biopsy. Okay? What I mean, be uncertain to give the definite diagnosis at the end. This is a general advice, not only you. All of us, when we mention the presentation, most likely this patient is having a condition 1, 2, 3. Or if you are answering the patient, mostly you have a condition called inflammatory bowel disease. Don't bother about the name, and it's a condition in which there is soreness and blah blah blah. The last question also, or two questions also, I prefer to ask in diarrhea questions I mentioned before. Is it related to certain type of food, and does it awake you from sleep? This question will direct you to either celiac or inflammatory bowel and roll out irritable bowel. Okay, we can move to the next scenario. Dr. Muhammad, your patient name is Mona. She is 35 years, came with fainting attacks. We'll give you 2 minutes. I will try to read the comments until you will be ready.
Dr. Bassam.
Yes, Dr. Asa.
Actually, my first diagnosis is an inflammatory bowel disease
Yeah.
complicated by sclerosing cholangitis.
Yes. Yeah. Yes, it is. Okay. By the way, the antibody is here, Dr.
Yes,
Dr.
you are
Huda.
right.
Yeah,
Priyanka, yes, you are right.
P. Anka. Yeah, I think you said I don't know, so it is P. Anka, Dr. Huda. And for the Crohn's, it's ASCA.
Ask. You are
Yeah,
right.
and for both of them, fecal calprotectin. Okay. The image, yeah, ultrasound roll out any organomegaly, and always remember to do test for lymph node. If there is lymph node, you have to offer lymph node biopsy as invasive test. The invasive test here will be endoscopy or colonoscopy for biopsy. And you can, if you are sure about the knowledge and the information about the biopsy finding, take the doctor or the examiner toward this side. I mean, if you are sure about skip lesion and lead pipe appearance, go ahead with this finding. I mean, in the exam, whenever you are good in certain information, just mention them, and the examiner will go more with this. And if you mention it, you will get, of course, the mark for it, as I mean the clinical judgment, as well as you will waste some time in the point you are perfect in. So if you are aware about the difference between the pathological finding of Crohn's and ulcerative colitis, start to mention them. And believe me, whenever you start, he will go deep with you in this part, and you will get a good mark in these points. Okay? All of us know about the finding in ulcerative colitis and the finding in Crohn's, the cobblestone, and here you will find skip lesion. I guess all of you know about them. I will try to read the comment quickly. Yeah, please don't say abdomen, Dr. Hoda. Say tummy. Swelling jargon. No, it's not a jargon. Swelling, something everyone knows about it. It's not a medical term. And if you are worried, you can say lump. Lump is a main complaint in medicine. You have any lump anywhere? Could someone, okay, you can, okay, bleeding anywhere else? Cancer colon, I mentioned. Spontaneous bacterial peritonitis because of fever. Again, if there is ascites, we have to put it. Ulcerative colitis, Bianca, anti-smooth muscle antibody, and ASCA for us for Crohn's, Dr. Azhar. ASCA for Crohn's, not for Clostridium difficile toxin. This is the screening and the investigation of pseudomembranous colitis. Sigmoidoscopy, yes, one of the invasive tests. System review were missed, yes. Whenever the complaint is fever, jaundice, diarrhea, sexual history is important. Travel is a must. I agree. 100%, Dr. Mona. Thank you. Yeah, this is the way how to enumerate the investigation: general, specific, bedside, imaging, non-invasive test, and finally the invasive test. Try to mention this way and this approach when you answer the investigation for any investigation in the examiner time. They will like this way. They will know that you are systematic, you are organized, not only mentioning anything, the blood test, and you can mention some of blood test without mentioning the specific. They prefer to specify tests rather than mentioning general investigation. Ischemic colitis also differential. Yeah, we mentioned that. No, sorry. Ischemic, we didn't mention it, Dr. Al-Rashid. Ischemic colitis, it will be in elderly patients for bloody diarrhea with abdomen distension. I agree, but it will be common with elderly patient. Postprandial pain should be asked with risk factor. Spontaneous bacterial peritonitis has bloody diarrhea. No, it's not. Unless he has some ulcers or esophageal varices, it will be melena more, as it is complicated always to end-stage liver disease or chronic liver disease.
Or perforation or
Perforation as well, yes. The pain also scale is very important if the patient is having pain for possible admission. Dr. Muhammad, you're ready? We can start.
Yes, I am ready.
Yeah, Dr.
Yes.
Dr. Huda?
Yes.
Okay, here you go.
Good evening, Miss Mona. How are you?
Hello. Fine.
Hello. Good evening.
Hello, doctor.
How are you? Are you Miss Mona?
Yes.
I am Dr. Muhammad. Today I will discuss your health condition. Okay, take some history and doing physical exam. Is that okay with you?
Yes, it's okay.
Okay. Would you tell me what's happening with you, Miss Mona?
Yes, I have this fainting attack recently, and I came to know the reason for it.
What do you mean by fainting? Please.
Yes, I just fainted and black out suddenly, and didn't feel anything. And within a few seconds, everything was normal.
Okay. When was that happening?
Like 1 day ago.
1 day ago. What were you doing before the fainting?
Yes, I was sitting normally, and then when I stand at this, I have this blackout and fainting.
Mhm. Was there any injury or trauma to head
No,
before the attack?
no, doctor.
No. Did you sleep over anything?
No.
Mhm. Just for a single time?
Yes, this is the first time.
Uh-huh. How long was the period?
It's for a few seconds,
Uh-huh.
I think.
Did anyone notice or witnessed this event?
No, I was maybe my husband see me at that time, and he mentioned that I fainted suddenly for a few seconds, and then after that I was all normal.
Did she notice some jerky movement of your arms or
No,
limbs? No. Any tongue biting during the attack?
no,
Uh-huh. Any wetting the clothes?
no,
No. Okay. Before the attack, did you complain of any dizziness or chest tightness?
no. It's all sudden, happened suddenly. But after
Yeah.
the attack, yeah, maybe I have just feeling some headache and maybe drowsy a little bit.
I mean, was there any sudden position change or some abnormal or bizarre movement before the
No,
attack? No.
no. Well,
Okay. Mhm. How long was the total period? It's around for
yes,
seconds or 1 minute?
yes, I told you, doctor. It's just a few
Just.
seconds.
Mhm. Uh, and how it's terminated?
I told you I just was sitting, standing, I fainting for a few seconds, and after that everything was normal when I lie down on the couch.
You didn't complain of any heart racing or abnormal feeling?
I have a heart racing, but not during the attack. I'm all the time have this heart racing.
Mhm. Since when you have this heart racing?
I think I have it for months.
Do you feel it's fast or you feel some irregular feeling inside?
Yes, it's fast, but no irregularity, no.
Anyone or any doctors seen this case, seen this event
No, I
before?
didn't seek any medical attention for
Uh,
it. I just
you
say
didn't
that
receive.
I drink a lot of coffee and I have certain stress in my life and leave it.
You have said. I'm sorry for that. Um, okay, Miss Mona, after the period of fainting, how was your feeling? Did you feel well or you gained conscious
Yes, I
directly?
told the doctor I feel conscious immediately after a few seconds, and I was just drowsy and have this just mild headache
Okay, how it's terminated?
by itself, doctor.
By what?
By itself, like I have
By
this.
itself,
Yes,
without aiding any
no,
medication or helps.
no,
Okay.
no
Okay.
at all.
Uh, do you have any headache or eye pain or eye blurry
No,
vision?
no,
No?
I no,
Double vision?
no double vision.
Any flashing of lights or zigzag lights?
No, at all.
No. Any arm numbness or weakness?
No, doctor.
You don't feel. Okay. What about control over the bowel?
It's what do you mean exactly?
You can control. Do you control your bowel
Yes.
by yourself, or you lost control
Yes.
recently?
No, it's normal.
Okay. Any tingling or any tinnitus or ringing sound in here, in
No,
ears?
at all. No,
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 not at all. Leg pain or leg edema, leg swelling?
no.
No. Okay. How about your memory, your concentration?
It's okay, doctor.
It's fine.
Um,
Okay.
mm,
Do you feel any slurred speech or heaviness in your mouth?
no.
No. Okay. So difficulty in swallowing, difficulty in speaking? No.
No difficulty in speaking, but swallowing, yes.
Mhm. Do you have difficulty in swallowing since when?
Yes. For months,
4 months?
yes.
Uh-huh. How was that? Did you seek medical attention?
No,
Mhm. Associated with any other symptoms like painful swallowing or
no painful swallowing. No.
it's to hard food or to the solid, to the liquid?
It's for mainly for solid food, yes.
Mainly for solid. Okay.
Mm,
Mhm. Do you have any rigidity in limbs?
you
In
mean stiffness? No.
stiffness? Okay. Okay. What about your is there any joint pain, joint stiffness in the
No,
morning? Not
no,
at
no,
all. Oral ulcer or
no,
skin lesion? No.
no,
Okay. Mm, Regarding the past medical, do you have any chronic medical like high blood sugar, high blood pressure?
no, doctor.
No. Any cardiac disorder before?
No.
Any neurological disease
Neurologic? No.
like migraine, like Parkinson?
No, doctor.
No. Okay. Have you done any surgeries before?
No surgery? No.
Okay. Any blood received before? Taken any
No,
blood or donated blood?
no at all.
Not at all. Okay. Any prior infection recently?
No,
No prior. Okay. Uh, do you receive any medication?
no,
Even herbal medication?
no at all.
Mhm. Okay. Is there anybody in your family complain of the same illness?
No,
Is there anybody having neurological disease?
no. My mother have diabetes, and my father have some thyroid issues.
Since when your mother has diabetes?
When since she was about 19, she have diabetes, and she's on insulin.
19. Okay.
Mm,
Okay. Do you have any thirsty or eagerness to drink or eat?
no.
No such. Okay. Any weather changes?
Yes. Not the weather changes, but I'm recently feeling more cold and prefer a warm weather.
Mm-hmm.
Yes.
Okay. Okay. Since when you have this?
Yes, for 4 months.
Okay. How about your bowel motion?
I feel more constipated than
Okay,
usual.
so you don't
Mm.
take any medication for this problem?
No, I try to drink a lot of fluid, and that's all.
Okay. Okay. Um, I have to ask some other question, including private questions. Is that okay with you?
Yes, no problem.
Okay. Okay. Do you smoke
No,
or drink alcohol?
no.
Okay. How's your period?
It's regular.
Uh-huh. You take any
Normal.
medication for hormonal medication for contraception?
No.
No medication. Okay. Do you have kids?
Yes, I'm married and
How
have
many?
2 children.
Mm, okay. Okay. Is there any specific habit?
No
No
specific habit.
habit. Okay. I'm sorry to ask, but we have to ask this question. Do you take any illicit substance?
No at all.
Okay. Sorry again to ask this question. Do you have any sexual relation out of marriage?
No.
No. Any traveling recently?
No.
No traveling. Okay. How's your stool color?
It's normal.
Normal. How's your
Yes.
urine color?
Normal also. No change.
Normal. I mean, there is no black stool or.
No change in my stool or my water work. No.
Mhm. Okay. Any skin lesion?
Skin lesion? No.
You don't have.
No.
Okay. Mm. Any cough, shortness of breath?
More of having, yes, a difficulty in breathing, especially in the last few months. Especially when I standing long time in my class and even when I do regular activity in my home.
It's related to the movement.
Yes, it's more on activity, yes.
What about rest?
Yes, it's better when I have rest.
Is there any leg swelling with it?
No.
No. What about sleeping? Do you sleep well
Yes.
without using frequent pillow?
No.
Okay. Any wake up at night from difficulty in breathing?
No at all.
Okay. Any cough? Any
No.
phlegm? Okay. Okay. Any fever?
No raising in
Ha-
my body temperature.
Have
I prefer warm weather, but no.
any recent weight change?
Yes, I've been gaining weight.
Okay.
Yes.
Okay. Let's go to the physical exam. Okay. Are you ready?
Yes.
Okay. Hand exam.
What you will look in the hand?
Leukonychia, koilonychia,
Yes.
skin, hair.
Negative, no finding.
Okay. Features of carpal tunnel syndrome.
Negative.
Pulse, vitals.
Yes, the pulse 100 regular. Blood pressure is normal.
Orthostasis.
Postural hypotension positive.
Skin color.
Negative.
Okay. Conscious state.
Sorry, consciousness?
Oriented.
Yes.
Totally oriented. Okay. Face, pallor, jaundice,
Pallor positive. Jaundice negative.
cyanosis.
Negative.
Any face weak, facial numbness.
No, negative.
Okay. Upper limb power,
Yes, the power is normal.
tone,
Normal.
reflex,
Yes, normal. No finding.
sensation, coordination.
Yes, coordination normal. Sensation normal.
Any lump in the neck.
Positive.
Okay.
Goiter.
Moves with swallowing.
Move with the swallowing.
2 minutes left.
Okay. Okay. JVP,
Negative.
cardiac pulsation, cardiac auscultation.
No, no murmur.
Normal. What about pulse rate?
Pulse regular 100.
Okay. Chest auscultation.
Clear chest.
Abdominal, palpation, hepatosplenomegaly,
Yes, splenomegaly positive.
splenomegaly.
Mm.
How's your temperature now?
Okay, proceed. Normal.
Okay. Okay. Any leg swelling, edema?
Negative.
Okay. Fundoscopic exam?
Sorry.
Eye exam, fundoscopy?
No need.
No problem. Okay. Lower limb exam, including tone, power, reflex, sensation, coordination.
Yes. The sensation there is loss of
What?
proprioception and vibration
Loss of proprioception. Oh, okay. Mhm.
till then.
Okay. Okay. What about Babinski?
Positive with a mute plantar. Ankle jerk.
Okay. You means dorsiflexion is positive?
Yes.
Mm.
No, mute plantar. Sorry. Positive ankle jerk with a mute plantar.
What's mean by positive? You mean hyperreflexia?
Doctor, just to proceed with the loss of vibration and proprioception up to the knee.
Up to where?
Up to the knee.
Up to the knee. Okay.
Mm.
Mhm. What about other sensation? Pain and temperature?
Normal.
Normal. Perfect. Gait exam?
Gait is normal.
Romberg?
Yes, Romberg is positive.
Positive. Okay. With eye closure or without?
Yes, with eye closure.
What about lower limb coordination was normal?
Yes, normal coordination.
Okay. Mhm. Perfect.
Dr. Mohammed, I will add 2 minutes for the concerns.
Okay.
Yes.
Okay. Do you have any concern, Miss Muna?
Yes, I want to know the reason for my fainting attack.
Okay, Miss Muna, where you were admitted to the hospital, you were complaining of a few seconds episode of fainting, loss of consciousness. According to the history and physical examination, um, there is some possibility that this loss of consciousness is related to the organic background pathology, including the thyroid and possibly to the blood or cardiovascular disorder. Apart from that, there is a possibility for some disorder, including the hypothyroidism. There might be also some loss of vitamin as part of some disease called autoimmune disorder or the weakness in defending system. So there might be a loss of some minerals in your body like B12, which makes all these changes and loss of consciousness. And also you have some background disorder, cardiac disorder, including the heart resting tachycardia, may be related to the some disease which is called inappropriate sinus tachycardia. Okay.
Yes, and what the differential diagnosis in this case for fainting attack?
Dr. Huda, you are done with the concerns?
Concern.
Yes.
Do
Okay,
you
now
have
the
any
examiner, you mean, right?
Yes.
Okay, examiner questions. You can start now. I reset the timer. Yeah, go ahead, please.
Okay, doctor. So the differential diagnosis for fainting attack in this case.
First of all, B12 deficiency, subacute combined degeneration of cord, but usually makes dropping or loss of balance. I will give a differential diagnosis. First, subacute combined degeneration of cord. Hypothyroid encephalopathy, but you have no confusion. Cardiac syncope. Orthostatic hypotension.
Yes. Okay.
Anemia possible from B12 deficiency. Okay. I think it's
Okay.
non-neurological cause of loss of consciousness.
Mhm.
Yes.
Can you tell me the link of this goiter and the neurological manifestation in this case? What's the link between them?
Goiter makes pressure to the surrounding structure.
Mm.
Okay, it can make, I'm not sure about this, but can make carotid pressure or carotid sinus hypersensitivity.
Okay.
One of the
So-
possibility.
Okay, so what the investigation you will send for this?
Okay. Basic investigation includes CBC, CBC, renal function, serum electrolyte, B12 level, blood film, and renal and liver function test. Then bedside investigation like ECG, echocardiograph, and vital sign fundoscopic exam, and other investigation for underlying pathology, including thyroid function test, TSH, and free T4, total T3, and CT scan of head, Doppler ultrasound of neck, Doppler ultrasound for carotid and thyroid ultrasound. Mm,
Yes. What do you expect to see in the complete blood count?
I can see hypersegmented PMN, neutrophil,
Mm.
and macrocytic cells. Yeah.
Okay, and the management plan?
Or maybe combine it, dimorphic red blood cell, including hypochromic macrocytic and macrocytic cell. Management plan, we have to start with MDT planning, including the neurological doctor, cardiac doctor, and special nurse, and admission to the hospital for full evaluation. This is first. Non-pharmacological measures, control of risk factors, and pharmacological measures. Although there is no specific pharmacological measure up to now, it's based on the pathology. But suppose the patient has hypothyroidism, we have to control the thyroid. B12, we can give IM B12. And if it's cardiac, I forgot to say we have to do also tilt table testing and other investigation like EP study and cardiac EP study. Yes.
Okay.
It's based on the pathology.
Okay. Thank you, doctor.
Welcome. What other question?
I don't have any other questions. If anyone could add, okay.
So what other imaging you can do here? He mentioned.
We need CT scan to rule out hemorrhage. We might need MRI brain to rule out the stroke, including posterior circulation stroke, and other imaging.
Give me the possible cause of syncope here and give me an order.
In order.
Yes.
Vasovagal syncope first. Cardiac syncope. Anemia. And
The vasovagal fitting this case?
I'm not sure.
Okay, perfect. Fair enough. Dr. Well done, Dr. Mohammed. Let's hear Dr. Huda comment, then I will comment.
Yes, this is a case of female presenting with the fainting attack. So the first thing would be the analysis of the postural hypotension. As she said, she have a dizziness from changing position, sitting to standing. So we will put the differential for postural hypertension and exclude any neurological causes as he do. Exclude any hypoglycemia and exclude for reason for this postural hypotension could be anemia, could be Addison disease, So this is the case of a female presented with postural hypotension, with goiter, with constipation, with a pallor. Okay, this is throughout the history. Throughout the examination, she have a goiter, positive, pallor was positive. On abdominal examination, there was positive splenomegaly. Neurological examination, there was posterior column affection. So all these signs of symptoms say she have signs of symptoms of hypothyroidism with associated pernicious anemia, associated autoimmune disease. So by taking the history, first analysis of the postural hypotension, is it from sitting to standing, exclude any neurological cause. I think what will give a clue in the history, one of the important thing to ask is any pallor, to exclude anemia, and then to explore the reason for anemia in this case, exclude any bleeding, or any associated autoimmune disease, such as in this case. Yes. So this is a hypothyroidism with associated pernicious anemia. That's my comment.
Yeah, perfect, Dr. Roda. Thank you for the case. It's a nice case with a good presentation and performance. Let me comment now on Dr. Muhammad performance. He did great. I think he was missed and he was lost during the history taking. And the way he asked the question make him more confused. And also he couldn't correlate the anemia to the possible cause of the syncope. That's why, Dr. Muhammad, you give a differential of syncope without target differential. So the first option here, as Dr. Huda said, the anemia. It started by the questions of pallor and the heart racing. I guess you got it from the question of any awareness of heartbeat. She said to you, yes, I feel it's fast. And you ask, is it irregular or no? She denied. I think that time you were confused and you didn't ask more about the arrhythmia, where exactly, when. And I think you asked about, is it related to effort or activity? Yes, it was related. But you didn't link it to the case. It was like just positive finding, but you didn't put it as a cause of syncope. Again, syncope causes and basis is very clear, and accordingly you can put it in order. Let's start with the most common, the cardiac causes. Clear, either arrhythmia or aortic stenosis. This is the most common cause as a cardiac cause of syncope, either pacemaker, aortic stenosis, or arrhythmias, either congenital arrhythmias or arrhythmia related to MI acquired, I mean. So these are the possible causes. And according to the age, you can correlate. I mean, in the young age, you can suspect the genetic cause of arrhythmia, and as well as for HOCM. In the elderly patient, you can suspect MI, arrhythmias, and aortic stenosis. Okay, these are the possible cause of arrhythmia related to the cardiac syncope. The second most common, if we suspect anemia as a common association either to autoimmune, yes, anemia is one of the most common cause of syncope in the basis. So the possible cause of anemia according to the type of anemia, whatever. The most common presentation as in this patient, autoimmune. Okay, or any other anemia, iron deficiency anemia, normocytic anemia due to chronic disease, or macrocytic anemia, or whatever the cause of anemia. Just put it as a differential. The third cause, epilepsy, and clearly you will know from the episode, the patient lost the conscious level. He was confused after that. He had jerky movement. You roll it out already. And the post-ictal state and loss of control over the urine, and bowel. This is the third cause. So we have anemia, we have cardiac, we have the case here, anemia, sorry, and the third was epilepsy. The fourth is hypoglycemia. Hypoglycemia, clear, the patient would be diabetic for a long time. He had awareness or unawareness according to the case presentation. The fifth cause will be neuropathy, either related, autonomic neuropathy, either related to uncontrolled diabetes or HIV or alcohol or whatever. These are the most common causes of syncope in base. I forgot to mention also stroke and epilepsy. Sorry, stroke and TIA. Stroke and TIA, it will be presented with neurological deficit, clear, either persistent, it will be stroke, or just for less than 24 hours as TIA. So these are the cause of epilepsy, of syncope in patients. You can rule out, of course, the vertigo as you ask, you feel spinning around, but it will not be like this presentation, okay? And the good thing you asked earlier, what you mean by syncope or fainting, and you have to analyze it as you did before, during, and after. Before, during, and after. Before, who was witness with you, who's sitting with you, you feel what, any sweating, any hunger, pain, to rule out hypoglycemia, and blah, blah, blah. I mentioned the causes, and according to each cause, you have to rule out them during analysis, during and before, and during and after. Every question will direct you to roll out or to roll in the cause of your syncope. Before, as I said, any hunger pain, it will roll out hypoglycemia. Any during, did you bite your tongue? This is for epilepsy. Palpitation before, so it will roll out cardiac cause. During also loss of consciousness, it will go more with the epilepsy. The hypoglycemia, I said the question of hypoglycemia, do you feel hunger pain or tummy pain and sweating? And after, the question for after, just to confirm, is it post-ictal? Did you regain your conscious level? For how many? You have to ask also about anyone checked your blood pressure, anyone checked your blood sugar, and also the causes or the harm or the complication of loss of consciousness. As you ask, any trauma, did you hurt your head? It's very important, okay? Of course, the activity during or before, like walking or sitting, standing suddenly from standing to sitting, from sitting to standing position. All this question will guide you to the case. Okay, let's talk about our case today, anemia, as a big reason of syncope. You have to know about the pallor. Anyone told you you are paler than before? And to suspect autoimmune association. She mentioned clear, I have intolerance to cold weather. So it's clear it's hypothyroidism. Either to analyze the hypothyroidism signs and causes, signs and symptoms. Here, she mentioned already constipation and also the intolerance to weather. But I don't know why you didn't analyze the hypothyroidism causes. It's important to know. Once you ask about the pregnancy and she told you, I have children, you have to rule out postpartum. You have to know what the cause of her hypothyroidism. Is it postpartum? Is it post-infection? You have to know your thyroid cause in this case. Okay, the female history, whenever you start to ask them, be sorry, I'm sorry to ask this personal question and sensitive question. And you have to ask about 3 Ps. All of us know about the 3 Ps. Pregnancy and periods and pills. Don't stop with one question. Ask the 3 questions. All of them will guide you to something. Here, you might have a change in the form of menorrhagia as hypothyroidism. The birth control pills can guide you any clotting in the history, and it might also be related to antiphospholipid or systemic lupus. And the third is pregnancy, and the last baby child age, to know is it postpartum or not. I think you went through the system view disorganized, and you have to do it in a systematic way again to train about that. Be systematic, be organized. Apart from that, you are doing great. And also the jargon I mentioned already in the chat box, neurological, you repeated the question. Do you have any neurological history, either in the family or you? How she knows, I don't know. She answered you clearly that yes, I don't have. Again, Dr. Huda, if you feel, just to remind him, if you feel the question is medical term, tell him what I don't understand what you are saying. It's a matter of reminding. Because if you just skip and answer him, he will repeat the question. He asked you once and you said no, then he asked you again in the neurological family in the neurological history in the family, and you said again no. And you are a surrogate or the patient. Suppose you don't know what is the neurological, right? He asked also about cardiovascular, and suppose he will ask any heart question, any heart condition in the family. Okay. So, Dr. Muhammad, you are doing great. I think this is the first time as clinical practice, but believe me, with the practice and the training, you'll be much better and professional.
Sure.
Okay. You have any question about the case?
No, I was thinking this patient might have some serious pathology like CNS or cardiovascular, but it was related to the hematological anemia,
Yes.
which is common
Okay.
among female.
Yes, exactly. Write the causes I mentioned to you, and with the time, you will know how to screen about them. So,
Mhm. Go
okay.
ahead.
Again, write the cause I mentioned to you. Then you will be able to ask about and to screen about them. Okay, Dr. Muhammad.
Yes, yes, Dr. Bas. Yes.
Dr. Basu,
Yes, go ahead, Dr.
this is a very, very long scenario. We have to examine the thyroid gland. We have to examine the just neurological features. I think that it's a very
Yeah, exactly. Yes.
examination. And
Yeah.
moreover, I just want to comment on Dr. Muhammad Sarda. He is doing well. He was asking two questions like, do you have any speech problem, any problem with the uh, swallowing? And sometimes he was asking, you have tinnitus. So please try to ask one question in the
Yes.
examination. The surrogate will answer for the last question. Like if you will ask to you have any speech
Mhm.
problem, any difficulty swallowing, he will only answer you about the last. And he was so please avoid jargon like do you have any urine problem, any rigidity, any tinnitus like this. And during examination, he did not do the examination of the thyroid gland, and he was doing the neurological examination was very good. So it was a very history was very lengthy, and examination he could not complete.
Yes.
Yes, this
I
is
think,
my
yeah, with the time, he will manage the time well with the practice.
point.
Thank you, Dr. Azhar.
Yeah, I encourage you to practice more, Dr. Muhammad, just to manage your time in the future. In the exam, you don't have the time to ask all these questions. You have to be targeting the question, as well as you will have time to do perfect examination. In this scenario, the thyroid examination itself, it might take at least 2 minutes. If you miss them, I guess you will miss the mark for a physical finding as well as for identify the finding. Physical examination and identify the finding. Because thyroid here is positive. I should do full examination of the thyroid. Okay. S- Of course, the steps are inspection, palpation, percussion, auscultation. But for the short time, because of the lack of the time, you couldn't do all the steps. You just ask her to swallow water and you just inspect the thyroid gland. But still, you are missing a lot of finding in the examination, the lymph node as well. So it's a matter of time, and I guess you'll be more professional.
Dr. Huda, I want to ask you one question from you. Why this patient was having difficulty in swallowing?
Thyroid.
Thyroid
Thyroid.
pressure.
Yes.
Why thyroid? So mostly this is a patient is having a goiter a lot.
Goiter, yes. Yeah. The large goiter can cause dysphagia, right?
Yeah, it was
Yes.
misleading, Dr. Huda. It was
Uh,
misleading, but it was a good
no,
comment.
no,
Yeah.
no.
I want to point more in the history
Yes.
that she's
Yes.
have really hypothyroidism
Mhm.
because it will lead you to the diagnosis a goiter, a constipation, whether a preference. I want to make the history more short just to
Yeah,
focus.
she was
Um,
helping you, but
Dr. Huda, what was the relation between the carotid and the thyroid?
what the relation? What do you mean?
I mean, is there any trigger or can thyroid pressure makes syncope over the carotid? Means thyroid pressure
No,
over the
no,
carotid?
no,
no.
it's anemia.
No,
Yes,
no, she
it's
did not
Anemia.
mention any carotid. You
syncope.
mentioned about the carotid. He did not mention any carotid. You mentioned about the carotid.
Yeah, you are pushing to CNS cause, Dr. Muhammad. That's why you are.
Yes,
No,
I
it's
was
not.
confused from CNS.
By the way,
Sorry,
it's very.
the history, you just focus a lot on the CNS analysis.
Yeah.
Hmm.
Whenever you are trying to push the case toward something in your mind, you will fail definitely. So try not to insist on a diagnosis. If it is out, suspect something else. Think about other causes. I mentioned to you again. So cardiac, epilepsy, hypoglycemia, and anemia, and CNS. These are the common causes of syncope in patients. If you roll one of them out by two questions at least, then it is out. By the way, you can add to them vasovagal attack, but vasovagal attack will be clear and two questions can diagnose them. It's coming with an anxiety or standing for a long time or with hot weather or with stress. These are the possible trigger for vasovagal attack. And everything will be negative. You have to rule out other causes. If vasovagal attack come in exam, you have to rule out all the other causes, cardiac cause and the CNS, and for anemia and epilepsy and hypoglycemia. But you will confirm them by the three questions as I mentioned. Panic when you feel panic, or you are standing for a long time, or you are in hot weather. These are the vasovagal triggers. And once you have them, you can say it clearly. Okay, so the position is very important.
And for the large goiter, and the three questions very important. It is compressing on the chest, shortness of breath,
Yeah,
difficulty
yeah,
in swallowing, and then the change in your voice. Three questions.
yes, yeah. So you have to analyze them more, the goiter itself. Okay, it's
So,
nice case. Yeah. Go ahead, Dr. Rashid. Hello.
mm,
Sorry, we can't hear you. 1 second.
Shayman was the fainting and fatigue headache. What was for this headache?
There is some break in your sound, Dr. Rashid. Can you repeat the question? Okay, please reconnect back, Dr. Rashid. I want to
Yeah,
add.
yes.
Yeah,
She
yeah. Go
mentioned
ahead.
there is headache with
Yeah, yeah,
post-fainting headache. That is sound like as epilepsy. Okay, but it's very short. It is not epilepsy, definitely. In this case, why
yes.
she mentioned this headache, post-fainting headache?
Anemia has headache, right? Anemia itself can cause headache.
No, post-fainting. She said someone can see.
I
I
believe that
see it's drowsy more than a headache. Yes.
there is drowsiness. Anyway, it will be more, not more, it will be continuous headache, persistent headache, like before and during and after, because of the anemia. Anemia itself can cause headache. If she mentioned headache, I think she said now it was drowsiness only. Okay, thank you, Dr. Rashid. I want to correct.
Okay.
Yeah, thank you. I want to correct a concept, Dr. Muhammad. You said the rhomboid test positive while opening eyes or while closing eyes. It is the test is while closing eyes.
Yes, doctor. I was confused with Hilton test. Yeah.
Okay, so don't ask this question in the exam.
Yeah, it's a pleasure.
Yeah, it will show the examiner that you are confused with the diagnosis itself or with the test itself. So it is only while closing eyes.
Mhm.
Any other question or comment from you, Dr. Hamad and Dr. Huda? I will try to read the comment quickly.
Dr.
Anyone
Basu,
has? Yeah, Dr. Azhar. Yeah.
if Romberg test is positive in
Yeah.
while opening the eyes, so it can be cerebellar,
Yes, exactly. This is ataxia.
cerebral ataxia. So
Yes.
what I could not understand what you said that don't ask this question in the exam.
No. The Romberg test only while closing eyes. The Romberg
It is
test itself, when you stand and close eyes, this is the term of Romberg test. If you
so
want to,
it means if Romberg is positive on closing the eye, it means the sensory ataxia.
yes, exactly. This is the definition. So Romberg test, doing the test while closing eyes, and if positive means this is dorsal column, and in another term, it is sensory ataxia. If the patient has ataxia while opening eyes, this is cerebellar ataxia,
Well,
and this is not Romberg. This is cerebellar ataxia. So whenever you ask him to close his eyes, now you want to do the Romberg test. Okay?
Oh, so you mean to say for Romberg test, we will only say Romberg is positive or not. No need to say closing eye or open eye.
No. I should ask him to close eyes, and if the test is positive, this is positive to Romberg test, and this is sensory ataxia. I mean, the test will be done only while closing eyes. If he is unable or ataxic while he's opening eyes, no need to do the Romberg test because he will be more ataxic. Imagine you are doing balance tests while he's opening eyes, he's unbalanced or he's not maintaining his steadiness. You got it? So if you close his eyes, he would be more imbalanced
But I
or
think it is
unsteady.
different, Dr. Bassem. You can, with cerebellar manifestation, you can find also the sensory. So in cerebellar manifestation, like say like Friedrich ataxia, he has cerebellar, but you should also examine for sensory and it is positive.
You mean
Maybe
the
by
coordination?
he is cerebellar. The Friedrich ataxia has both
Okay,
cerebellar and sensory.
okay.
So if
Yeah,
you will
I got
find
your
the
question.
cerebellar,
Okay,
yes,
I got your question now. You can do the joint and deep position.
yes, but also you should offer the Romberg test because it is a confirmation of sensory ataxia.
Okay, I got your point, but he will be more unsteady. So you can diagnose it
Yes,
with the
you know,
sensation.
and they may say no need like that.
Okay, you want to
But
offer
like
without
in
doing. Okay.
say in yes, in some patient they should know that it is sensory or pure cerebellar.
Okay, I got your point.
Dr.
Okay,
Bassem,
Basu,
yes, Dr.
what I
Mohammed.
got from you
that,
is that Romberg is only positive on closing eyes.
Exactly.
You mean,
Yeah.
bas.
It
When
is
you want to,
it's the test, the name of the test. So it's the test
yes,
when you close the eye. No, no
exactly.
test.
If
No, yes.
Okay,
yeah, if you want to
thank you
say
so much.
positive Romberg, suppose this test done while he's closing his eyes,
Okay. Thank you for
and
clearing. Thank you.
yeah, and he lost the steadiness. But if you didn't do closing to the eyes and he's unsteady,
I think it is equal to pronator drift if you can't
uh,
do.
pronator drift for stroke.
cognitive
No, no,
drift
no.
is another pathology, Dr.
Yeah, yeah,
Ahmed.
yeah.
Okay,
For
Another
closing
stroke,
or opening the eye should be done.
pronator drift for stroke,
It's for
and
corticospinal. Yeah.
yeah, and it is for while closing eyes as well. Yes, but this is in the hand
for
and
for stroke.
for stroke. Yeah, pronator drift is a diagnostic test for stroke.
Mhm.
Or it's called pseudoacidosis. Not a pronator drift, but even close his hand, close his eye and extend his hand, there would be abnormal breathing movement.
Reverse, this is called
Pseudoacidosis also point to posterior and sensory ataxia.
Yes, you are right.
Maybe this is yes. Maybe I'm confused by
Close
both.
his
Yes.
eye- Yes, close his eyes, extend his hand as he do.
It is the same idea of Romberg, yes, that you can't maintain something when you close eye.
Pseudoacidosis, maybe, I'm not sure.
Okay. Any other questions or comments?
Dr. Bassam, regarding the
Yes.
Hilshin test, again, the same principle applied to the Hilshin, like Romberg. Once you cannot do the Hilshin maneuver with opening eye, this means this is cerebellar. And once you closed your eye, you failed to attempt this maneuver. This is sensory ataxia.
Yes, exactly. Of course, with the background of deep position, deep sensation, which is a joint and vibration. So you cannot say it without testing the sensation, which is the deep sensation. You got it?
Yes.
So your evidence to say I have sensory ataxia, two tests, Romberg test and doing the deep sensation, which will be lost, either joint or vibration. Clear?
Yes.
Okay, any other question or comment?
Doctor, if
Alaikum
we
salam.
sorry.
Yeah. No, anyone. Yes, okay.
But I think Romberg test for diagnosis sensory ataxia. For that, ask the patient to close eye to examine the sensory peripheral sensory nerve.
Yes, this is what we said, Dr. Rasha.
Yes, okay, but different from the pseudoacidosis and different from post-pronator draft. I think pseudoacidosis in cervical myelopathy. When the patient close the eye, the patient do like acetosis movement.
Okay. Actually, I wasn't aware about pseudoacidosis test. This first time to hear about. But it's okay if it's clear for others, so it's good.
And also, I want to add something regarding pathway or approach of syncope. If the patient said from at the beginning, I have syncope when sitting or standing, that means that the patient put in my mind the differential diagnosis of boucher hypotension. One of them, Addison and anemia and loose diarrhea. And the patient like diabetes or the patient Parkinson's disease. If the patient said at the beginning, the patient, I have syncope from sitting or standing, you mean to ask about the differential diagnosis of boucher hypotension to manage the time. And also to know what exactly the case. Does the patient have a history of sitting or standing? You need to ask about Addison disease. If picked up the patient Addison disease, you wanted to know if the patient this Addison, isolated Addison, if there's Addison as the part of autoimmune polyglandular syndrome, or there's the patient the Addison associated with other autoimmune disease.
Perfect, yes.
Okay, just only regarding the cardiovascular examination, I want to ask if there's any heart racing, if there's any chest pain, quickly. If there's any weakness, if there's any headache, if there's any confusion, quickly. After that, if the patient the syncope, you need to examine about the cardiovascular examination. It's important to examine the cardiovascular examination. This is the patient. And also, if the patient sitting or standing, you need to ask about the medication. It's important. There's some medication like ACE inhibitor, like beta blocker, like diuretic, need to cause the boucher hypotension. This is for management the time and target questions about the case.
Perfect. Yes, you're right. So the position can guide you to the case. If he said it is from standing, from sitting, it will guide you to posture hypotension. And you can analyze it more, either the medication or cardiovascular or anemia, or Addison, sorry. Anemia will be with any position. It's not related to the position. It will be even with sitting or standing. But it will be more worse with the standing from sitting.
Yes.
Exactly.
Mhm.
Thank you, Dr. Rashay. So you added to them
Yes.
posture hypotension, which is also possible cause of syncope in paces.
Yes.
Perfect. Yeah. And the previous case also can have posture hypotension. I guess Dr. Muhammad didn't, or Dr. Huda didn't ask about the cause of the signs of posture hypotension or dehydration.
Sure. No, I asked. I
You
remember.
asked? Perfect.
Yes, I
Yeah.
asked about
Okay.
any dryness in the mouth, but
Yeah,
I
you
didn't
asked.
ask about any
Yeah.
change in the water work amount, especially.
Yeah, I mentioned already genitourinary. But
Yes.
in the examination, capillary refill, dry of the skin, dry of the mucous membrane,
Yes.
and posture hypotension, checking blood pressure sitting and standing. I think
Yes.
you didn't offer, right? Or you offer in the
No, I
examination?
offer it. No, no, I
Perfect.
offer it.
Okay,
But I
perfect.
have a question. If the
Yes.
patient already have hypotension, will I ask about the postural hypotension if he already have hypotension?
He has already hypotension. How
Yes.
much? How much? It will be at 90/60? Yes?
Yes.
Yeah, offer it. Offer it. I would like to do.
Even if he's hypotensive.
Yes, why not? It might be more signs of dehydration.
Mm.
Yes,
It will
sign
show.
of dehydration as the sign of dehydration, because one of cause of postural hypotension, diarrhea and lose fluid. Maybe patient hypotension and also postural hypotension as the
Yeah,
cause.
Yes, I
exactly.
know, but okay, but just yes, I
But
hear
you
it
will
from
offer it.
someone. Yes, I offer it. Yes, but I just mean if I see if I ask for blood pressure and he say it's hypotensive, do
So
I
no
need
need to mention. Sometimes,
Mm,
170, it's borderline hypotension, and it's could consider for him normotension, right? Some
mm,
patient with normal blood pressure, he will say, "This is my usual blood pressure, 100/60,
mm,
for example." So you have to offer also when I ask the patient to stand to check his blood pressure, offer it.
mm.
It will not harm your mark.
Okay, so regarding the dehydration, we will check mucus, we will check for
Yeah,
dryness,
yeah,
capillary refill, ask about the urine and
yeah,
blood pressure and pulse. What about the
exactly.
skin turgor?
Yes, yeah, one of them also skin turgor. Yes,
Okay, so we do it in this they
yes.
invaded. Okay,
So
yes.
there is questions in the history and there is tests to do. In the history, you can ask about the urine outputs, dryness, you feel thirsty, and in the and posture, you feel dizzy while standing from sitting. This is the question. The examination, you will do the capillary refill, the pulse, the skin turgor, mucous membrane, and I mentioned already the blood pressure sitting, standing. Okay,
Yes.
clear now? Yes.
Yeah.
Okay, thank you, Dr. Huda and Dr. Rasha. Any other question or comments? Yeah, Dr. Aisha updated the causes of syncope, anemia, Addison, dehydration, autonomic
The
neuropathy.
postural hypotension.
Yeah, that's hypertension.
Yeah.
Okay. Okay, thank you, Dr. Aisha. Anyone has comment or question? I will try to read the comment quickly. Cervical degeneration, Dr. Salma. Cervical degenerative disease due to compression by thyroid. It's far away, the thyroid from the cervical. I guess the thyroid is in front and the cervical. Sorry? Anyone talking? Okay. Anemia, hypotension, POTS. Yes, this is Dr. Rashid also mentioned. Addison, I wrote it earlier. You should roll out Addison. And whenever you have autoimmune, you have to ask about association, celiac, vitiligo, thyroid, and diabetes. Okay. Okay, pernicious anemia, autoimmune, hypothyroidism. Dr. Rashid, mashallah, earlier he caught
لا
the case.
لا انت
Sorry?
نبهتني الاديسون اديسون very important لانه كان بي cooked and easy to get in the exam. usually
Yes,
تركز في اديسون.
yeah. Yes, you're right, Dr. Rashid. Okay, other comments. No explanation for headache here. Anemia, as I said, also autoimmune, sweating, history, fainting. Yes, pernicious anemia. Character of the pulse very important here to be illicit. Is it already pulse for hypovolemic, weak pulse for aortic stenosis, and pacemaker exactly? So the pulse itself can guide you and can be a clue for you. I think. Thank you, Dr. Rashid. Dr. Mona, I think it's too much for one case because of the time limitation. Anemia in the first presentation with undiagnosed hypothyroidism because we need to explore the underlying cause for both. Also, exam will take time. Exactly. I believe Dr. Muhammad, he will do better and more professional in the next times. Thank you, everyone. I think satisfied now with the two cases. Anyone has comment question before ending the session?
Thank you, Dr. Bassem.
Thank you, Dr. Muhammad. And really, you are doing great. You are in the right track while you are volunteering to practice. It's better than listening. And please, next time also, again, be volunteer. Try to practice more and more, and you'll be more professional. Thank you, Dr. Huda, for the first practice.
He is perfect. Just don't be more
Yeah,
detailed, Dr. Mohammed. You are very focused, mashallah, and you search for complication. So you are very detailed in history. Just skip. Try to
Yes.
skip to save your time and to elect the common
exactly.
things.
Yes.
Yes. Thank you, Dr. Aisha.
Yeah, thank you. Thank you, Dr. Aisha, also for your comment.
Muhammad, he is doing mashallah very well. He's doing very well.
Thank you, Dr. Azhar.
You see how many supports you have now?
Yeah.
Yeah, I guess you'll again
Yeah.
volunteer for the next time,
Inshallah.
inshallah.
Okay, inshallah.
Okay, hopefully we'll see you tomorrow, inshallah, the communication day. Thank you everyone for attendance. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.